Today I'm going to be talking about the findings from the MEDLEY-AID trial, which stands for medley after an incident of acute decompensation. And just before I start, I just want to probably disclose that I am one of the co-inventors of MEDLEY. So what is MEDLEY? I think many of you already have heard of MEDLEY. It's basically a remote patient monitoring or management intervention that is developed at University Health Network. Is based on a platform that includes a smartphone interface for patients, and it is a Class 2 medical device. So here's just a quick diagram of what the interface looks like for the patient. So they basically take daily measurements of their blood pressure, their weight, and then they enter some symptoms. There's a background of an algorithm that sends a self-care message based on their readings and on their personal thresholds. And of course, they could take a look at all of their data through the app as well. And just very quickly, on the clinical side, depending on the readings, there could be an alert that's sent to the clinician through an email often, and they could also log into the clinical dashboard where they can get all of the patient information as well as the alerts that are generated. So over the years, we've done many MEDLEY-related trials. I just wanted to kind of highlight here that it was 2016 that the MEDLEY platform was actually used as a standard of care. And the trial that I'm talking about is kind of placed a few years after that. And there was two main reasons for doing this trial. One was that we wanted to really kind of get outside of UHN. So UHN is a bit of a unicorn, right? And so we wanted to see how it performed in other academic and community sites. And the other difference was that we really wanted to see what happened when patients were recently discharged from hospital. So those were kind of like the two new features of the MEDLEY-AID trial. So there were two hypotheses. The first was that the implementation of MEDLEY would be feasible and safe at both academic and community sites. And the second hypothesis was that if you have MEDLEY within 2 weeks of discharge, it would help the patients in terms of self-care, quality of life, as well as clinical status as well. So the study design, it was really a pilot study, RCT. It was multi-site and multi-method. It was at the 3 sites of Sunnybrook, Mount Sinai, and North York General Hospital. We did a sample size calculation based on the SCFI, which is the Self-Care Heart Failure Index, and so we came up with 144 target participants. The idea was we would follow the patients for 3 months. We would also ask the patients to have a baseline and end-of-study questionnaire that they would complete. And we also interviewed a number of providers and patients, and they were pretty much equally distributed across the 3 different sites. So here are the inclusion and exclusion criteria. I'm not going to go through this in depth, just to say that for all the patients, they had to have been hospitalized for decompensated heart failure within for at least 24 hours, and they had to be discharged within the last 2 weeks in order to be eligible. So here are the outcome measures. Again, I'm not going to go into all the details here. I already talked about that we were powering it for self-care. We had quality of life measurements, including the KCCQ, as well as the EQ5D. We looked at the NT-proBNP values as part of a prognostic marker for the heart failure. We had NYHA class, as well as looking at the compliance of using MEDLEY. Some of the secondary endpoints are also listed there, but obviously we weren't really quite powered for those, but included things like hospital readmissions. And we had some safety endpoints, including some blood work. So, long story short, we weren't able to actually meet our target of 144 patients. We were able to recruit 91 patients. We actually over-recruited. We were trying to aim for about 48 patients per site in terms of the Sunnybrook site, and that was because we started and finished before the pandemic. So the pandemic happened, and obviously we had to stop recruitment because we couldn't, the hospital had to redeploy the clinical staff. And so, and then when it started up again, we had to do remote recruitment. During the trial, we also had a hiccup in terms of the Mount Sinai site they actually had a standard of care program of Medley created, and so of course we could not run the RCT as well because we couldn't recruit the controls. So in particular, kind of thinking through the community sites in Norfolk General, we also had other recruitment challenges. There was some buy-in from the clinicians that was challenging, and also the workflows were a bit challenging as well to recruit the patients. The other issue here was that a lot of the patients who were eligible at the community site weren't actually going to be followed by the cardiologists there, so again, that became an issue and we couldn't enroll them into the study. And finally, looking at the kind of different demographics of the patients, a lot of them had challenges or the inability to actually use Medley for things, for reasons such as language, digital literacy, et cetera. So that was another limitation. So here's the list of the patient characteristics. Again, not going to the details, but here I just want to point out that the average age of the patient was 72 years old. And compared to our kind of previous Medley trials, this was actually a lot older, where in our UHN trials, they were generally in like mid-60s. So this just to say that we are actually trying to, we were able to kind of get the patients we were wanting to recruit, which is the kind of the elderly patients that we're accustomed to in the community with heart failure. So in terms of the SCFE and the KCCQ, we actually didn't find a change, which was a bit surprising because we have usually found an improvement, and it could have been a sample size problem. In terms of rehospitalizations, also we weren't able to see any differences there, including the length of stay, but again, we weren't really powered for that. We also, in terms of the safety endpoints, which was good, we didn't see any kind of differences in those blood test values. However, we did see a statistical significant change, improvement in the change scores between groups, and so at the 1 month and both at the 3 month as well. So that was a bit surprising considering we also had a very small sample size, so that was encouraging. We also saw in our previous trials and studies, this was the case in our Medley trials at UHN. So just talking a little bit about and switching gears to the patient interview themes, we basically found that the patients thought it was quite easy to use. They used terms like it was foolproof. It was very easy for them to get into routine by using Medley. And in fact, when we looked at the adherence data, we found that on average, patients were able to take about 80% of their daily measurements. And this was an underestimate because obviously we weren't even looking at when they were away on vacation or if they were hospitalized. There was also, at the beginning, a fear of the self-management, and so they had some anxiety, but as they got used to using the technology, this kind of fear diminished. And in fact, by the end of using it, a lot of the patients felt anxiety when they weren't able to put the measurements into Medley. An important theme that kind of got reiterated in this study is that it allowed them to do self-monitoring and to kind of correlate these behavior changes with the outcomes of their health, which was really important. And I'm just pulling here a bit of the kind of patient questionnaire data, and again, I'm just going to show very few data points here, but just to reiterate that the patients found that Medley was quite easy to use, that they thought that they perceived that it helped improve their health in general. And they also thought it was useful to continue using Medley. So again, it was kind of hard for them to give it up once they started using it. In terms of the provider interview themes, They also found that it was helping patients adhere to both monitoring of their conditions as well as to adhering to taking their medications. They thought it was kind of like taking the thinking out of it. They also found that, and this kind of mirrors what the patient said, it facilitated the patient education, and again, reinforcing that what they do in terms of their self-care behavior really impacts what is happening in terms of their heart failure health. And this was the last point here was quite important, is that when we interviewed the clinicians, they found that there's not a hell of a lot of benefit if the alerts are being sent, but there's nothing you could do about it. So for example, if the patients had fluid retention, but there was no acute diuresis clinic, then it wasn't really helping the patient. And as another example, clinicians were saying, with their workload, they weren't able to promptly talk to the patient if they were alerting. So again, the benefit was diminished there. So just a few conclusions here. Basically, we did find that it was feasible and safe for Medley to be implemented in community and academic sites. We found the improvements in the NT-proBNP, but the other metrics were likely underpowered. We found that the patients and providers both perceived that there's benefits for Medley, and there was a lot of additional recruitment challenges particularly in the community compared to what we found at UHN. And finally, again, just to reiterate that it's really important to have the clinical workflow integration as well as these pathways to do something about the alerts if we want the patients to really benefit. And just to acknowledge our funding sources for the trial and the huge team of clinicians and other researchers, and of course our patients who participated in our study. Thank you.